Yes.
Hello.
Okay, so it's an honor to introduce our today's panelists, Dr. Basim Alhassan, who is currently working as professor of orthopedics at Harvard Medical School. He did his medical degree at American University of Beirut and orthopedic residency at University of Illinois, Chicago. And then he did his fellowship in hand and upper extremity at Mayo School and his fellowship in shoulder and elbow surgery at Mass General Hospital. He joined Mayo Clinic in 2007 and worked there for 13 years, after which he moved to Mass General Hospital as co-chief of shoulder surgery and program director of shoulder surgery fellowship since October 2020. He has developed 20 new surgical procedures for shoulder, elbow, and wrist through dedicated anatomic and biomechanical studies. He has published over 125 peer-reviewed articles and authored 30 book chapters. A few prestigious awards in his kitty include Senior Alpha Omega Alpha Honor, Robert Ray Award for Research, Mayo Clinic Teacher of the Year Award consecutively for 2009 and 2010, and he is also the recipient of ASES Traveling Fellowship Exchange Program for 2015. I welcome you, sir, and I'm looking forward to hear all the interesting things you are going to tell.
Thank you.
Our second panelist is Dr. Praveen Bhadwaj. We all know him. He is consultant hand and wrist surgery and reconstructive microsurgery at Ganga Hospital, Coimbatore. He has 109 publications, and he is currently the chief editor of Indian Society for Surgery of the Hand and the editor of Journal of Hand Surgery Asia Pacific Volume. I welcome Dr. Praveen and I hand over to Dr. Maulin for further proceedings.
Thank you, Gaurav. I'll share my screen. So, Basim, and most of you know that this is every Thursday morning, we have academic meet for fellows, and the alumni of Orthokids is spread across India. So all the fellows and colleagues, they participate. Now, me and Praveen have been seeing some different or atypical signs into brachial plexus palsy. And why I have chosen two of you is because whenever I talk to you guys, I thought that we are on the same page. Rest of the times I could not connect to people because their ability to understand this problem or our limitations in catering this brachial plexus children was not convincing to me. So I was looking for this chance to have you with us, and thanks for your time today. So without wasting time, I'll start my proceeding, and Praveen should join in a moment. So the findings or the patients which I'm presenting here is a part of my team. We run this comprehensive brachial plexus clinic in Ahmedabad for last 13 years now. In Ahmedabad, Dr. Nishchal is my plastic surgeon colleague, and Dr. Tej is a pediatric rehab specialist. And so this data is from our clinic. Now, we all know that the residual weakness in obstetric brachial plexus palsy due to early recruitment of internal rotators and adductors leads to weakness of external rotators and abductors. And the typical signs we see is limitation of passive external rotation and development of early internal rotation contracture. And through our studies on ultrasound, we have found that these signs, they come pretty early in the life. We see a lot of infantile dislocations. Another typical sign is the arm internal rotation posture. And when a child is asked to reach to mouth, child has to lift the arm, or sidewise, they have to abduct it to reach to the mouth, and that is known as trumpeting or typical lateral trumpeting. And this arm chest angle has been measured as an angle of trumpeting. The third clinical sign is a proportionate limitation of shoulder abduction and external rotation. The C5-6 cohort or typical Erb's palsy cohort has major limitation of external rotation, And in similar fashion, they have abduction limitation, although we see some children who has very good degrees of abduction in the presence of internal rotation contracture. So these are the typical signs we see in Erb's palsy or C5-6 affection. And conventional treatment has been release of subscapularis either through at the insertion or at the origin or through an arthroscopy, and transfer the conjoint tendon to balance the shoulder joint. Now, this treatment and strategies have been laid down for now centuries, and we have been following that. But we have observed some atypical signs in some subset of patients, and those are a disproportionate limitation of shoulder abduction and external rotation, and which we test by what we have termed it as a pedicab test, external rotation contracture, and forward trumpeting. So I'll take these signs one by one, and then I have input from my panelists about them. What I mean by disproportionate limitation of shoulder abduction and external rotation is, in typical Erb's palsy, there is a proportionate limitation of external rotation abduction, but there are some children who have good degrees of active shoulder external rotation in both shoulder abduction and shoulder adduction. But when we ask them to do elevation, they flex their elbow and they stuck at 90 degrees. They cannot further abduct. Now the question would arise at why this happens, because the abductors are supplied by C5-6, so as the external rotators. So why the external rotators are spared? So we've digged into the literature and we found that Dr. Gilbert from France says the shoulder instability might prevent deltoid to produce abduction. In nutshell, he said that if there is shoulder is unstable anteriorly, then the deltoid and supraspinatus will not be able to lift it. Or David Chuang said that the co-contraction of shoulder abductors and adductors might be the reason of a child who is not able to elevate the shoulder in the presence of good degrees of active external rotation. So we moved further to do surface EMG. And in the cohort of 25 patients, we did not find any co-contraction between pectoralis major and deltoid. But instead, we found there were co-contraction between deltoid and biceps. So whenever a child tries to elevate, the biceps gets contracted and biceps gets tighter at the lower end. Probably it is not able to work on the proximal end. Furthermore, when we applied an elbow extension splint a bit rigidly, or what we term it as a paddy wrap, there is spontaneous improvement of this elevation. The child is doing 180 degrees of abduction with the paddy wrap application, and we term it a positive paddy wrap test. So the question is why this happens. What happens at shoulder joint that when we apply an elbow extension splint, child is able to do elevation spontaneous? This means that deltoid and supraspinatus is well recruited, but due to some biomechanical reasons, they are not able to work. One more finding we found in our patients is they had internal rotator and triceps weakness. Suggestive of this subset had C7 involvement as a part of affection. 40% patient had grade 3 Malay hand to spine, so they could reach to S1, not T12, and 60% could reach to the midline with wrist flexion. When we did the belly press test, they could not touch their palm to the belly. They required some degrees of wrist flexion. And about 70% of patient had MRC grade 3+ in triceps. So the triceps strength was suboptimal. So now my question to panelists about what do you think is the etiology or biomechanical reason of paddy wrap test? Praveen, are you there?
Yeah, very much there, Maulin. Nice.
Praveen, I'd like to know from you first, and you have also observed this in your clinical setting, and then we'll learn from Basim what he thinks about it.
So, yes, Maulin, as you told, this is one very kind of very strange phenomena what we see many times. So I think it is basically because of the anterior shoulder instability and triceps weakness. So these are the two things which are contributing to it in various ways. So if the triceps is weak, So what happens is, this is the mechanics which is there in my mind after seeing all these patients. So maybe Dr. Hassan would be able to tell us more about the biomechanics. So what I think is, if the triceps is weak, then patient, whenever they try to lift the shoulder, because of the deltoid biceps co-contraction, the elbow flexes. And if the elbow is flexing, the stabilizer effect of the biceps tendon as an anterior stabilizer to the shoulder is lost. So whenever you give a pedirap, elbow extension splint, the biceps now primarily starts acting at the shoulder as an anterior stabilizer. And then the deltoid and the supraspinatus are able to effectively lift the shoulder up. So this is the mechanics which is there in my mind. But there is a small group of patients in which triceps is grade 3 plus, it is quite strong triceps, but even then they are falling into this category. So they are the group who have a pure anterior instability where the subscapularis is totally not functioning. And these are the group who have a lot of limitation to the center of the body. So these are the two mechanics, and that's how they interlink to each other.
Right. So, Basim, what do you think about this test? And can you unmute yourselves? Yeah.
So I think what has been said is relatively correct, because anterior instability, the true anterior instability in obstetric almost does not exist. Don't take me wrong. What I mean is the instability that you see it in adult, you rarely ever see it in obstetric for many, many reasons. So while in obstetric, you see a posterior dislocation, glenoid dysplasia, you see bone defect is posteriorly, bone changes, acromial downslope, coracoid downsloping, retroversion. When you have this deficiency where the subscap is deficient, the glenohumeral joint almost always is concentric. You can see it concentric, nicely concentric.
Yeah.
And the shoulder is relatively unstable, not truly unstable, relatively unstable, because you don't see subluxation going anteriorly. At least I haven't seen it myself, for many, many reasons. Because again, in obstetric, like the way the bone changes over time, it does not really allow this frank instability. However, there will be a muscle imbalance. And what has been said right now is dead on. What I mean is, not true instability, but imagine if you have instability. For those of you who do sport, what is the test that we test the patient for anterior instability? Is the abduction external rotation test. So when you want to do an instability test, this is a test, abduction external rotation. So in these patients with the triceps weakness, when they try to attempt to flex the shoulder, because they have also external rotation contracture, they end up in this position, which is the instability position. And since the subscap is deficient, they end up stuck, because in this position, if the shoulder is unstable and the triceps is weak, they will not going to be able to raise their arm up because of this, again, imbalance of the shoulder that you have it in this situation. It is essentially the instability position. Now, the minute you put the elbow in extension, even in patients who have instability, I'm talking even adult true instability, they don't dislocate. It's very unusual, because the torque, the moment arm to dislocate, is not there anymore. And now you have a stable shoulder that you have it, and at the same time you tighten your muscle, you'll be able to flex the shoulder. So I think what has been said is correct, but it is like, it requires just slight tweaking and for this patient. And because I will really be very interested to see if patient, they have a posterior instability with internal rotation contracture, if they have this phenomenon. It will be very interesting, because for me, this is mostly for those who have an anterior subscap weakness or deficiency.
You're right.
Yeah, so
in posterior instability, people don't have this effect.
It cannot be, because in posterior instability, if you extend the elbow, they subluxate more posterior.
yeah.
That's the difference. The minute you flex the elbow, this is the anterior instability. Again, this is an adult, and I know some of you, they don't say adult, but this is typical. Flexion, external rotation, this is the instability anterior. When you flex the shoulder or you extend it, this is instability posterior. So in patient, in fact, if you want to try it, for those who have posterior instability, if you extend their elbow, they may lose some motion. But for
So-
anterior instability, they're gonna gain motion. That's what's gonna happen.
So my question is, do you say no to the biceps as an anterior stabilizer when we put a pedirep test, pedirep on? Because I have seen a few patients where I have operated upon where they have very poor triceps strength. Once I do pec major transpositioning, which I'm going to discuss later, their abduction improves from 19 to 180 degrees, but still their elbow is flexed. So even though triceps is weak, these children improve in their abduction fully. And when they abduct, their elbow is flexed because they cannot extend against gravity. There we have not applied any pedirep. So why abduction happens after this anterior stabilizing with a, with the pec major, I transpose or whatever you do, where tricep is still weak. And we don't.
I'm not very sure I understood the question.
Did you understand?
No, I did not understand. No, because you're asking me if I believe if the biceps, the tightening of the biceps is what stabilizes the shoulder, then you talked about the pec. I did not understand your question though.
So let's break the question. First is, do you think that philosophy that by putting an elbow extension splint, we are stretching out biceps and it acts as an anterior stabilizer, which helps in elevating and not the tricep strength?
I am not very sure about this because you're assuming that. However, what we are not taking into consideration, what's going to happen to all these muscles the minute you extend the elbow. So we're focusing mostly on the biceps, but in this setting, you have external rotation contracture, the humerus is slightly anterior, you're trying to tighten the elbow, you have the conjoint tendon on the coracoid, you have the biceps going to the humeral head, you have the origin of the triceps going from the glenoid, and at the same time, even though this is not going to affect it directly, like the remaining of the rotator cuff muscle also will be affected relatively. So my question is, I'm not very sure. The only way we will know if someone has, because I have the patients, but we did not do this test specifically on them, where they had the long head of the biceps was either cut or whatever from prior surgeries, and they still relatively show this kind of phenomenon. So I wonder whether it is long the head. If you're talking about the conjoint tendon, it is a possibility. I'm not very sure about the long head of the biceps, right, if this is a question.
And the second thing, what I have observed is, I was not, although I have seen that triceps weakness is a character of this subset of patients, but when we do this transpositioning, they improve in abduction to the full, where we have not touched the triceps. So
you mean if you do the pedicle pec, when you move the pec?
Yeah. When we move,
but this is completely different though, because I think again, if we're getting there though, if we are assuming right now that the patient, when they have weakness of the subscap, and it's an imbalanced shoulder.
Yeah.
However, this is the best looking bony shoulder, by the way. So when you compare internal rotation contracture to external rotation contracture, the biggest difference is the bone, because the bone is the best. The glenohumeral joint is the best shape. So now you have a concentric glenohumeral joint that you are creating, whether the deltoid is weak or not, but you are creating an anterior vector to balance somehow the shoulder. So if you try to saying, okay, what are the forces I have? F1, F2, F3, F4, F5. I'm talking about the triceps weak, you have posterior deltoid, no subscap, and you have biceps in the front, and you're trying to, each one of them is one force. And now you're adding additional force anterior with the pedicle pec. Now you're balancing the shoulder differently. So now we're talking completely about a shoulder that is somehow balanced with a weaker triceps. This is what I'm trying to say. One more thing, and this is, I know, like for you and the others who see the brachial plexus, if you look at the deltoid in these kids, many times, the deltoid is working. However, if you truly during surgery look at the deltoid, in many instances some of them, it depends if they have nerve surgery or not before, the anterior deltoid usually is weaker than the rest. If you look at the truly the strengths, you have middle, posterior, anterior deltoid. For those who have external rotation contracture, almost always, even though it feels they have a contraction, but the posterior and middle deltoid is better than the anterior deltoid. Now you're talking about something completely different because the balance of forces is different. We're talking about 5/5, 4/5, 3/5. And now you're trying to balance it again. So this is what I'm trying to say. There are a lot of variables in this situation. And I like the fact when you started your talk, you talked about something which I really like, is the fact that the kids dislocate early on. So all of you know Howard Clarks, who is a great surgeon from Canada. He talks about the cookie test at the 9 months. But many times I had debate with Howard Clark that the shoulder, like you said it in your presentation, if they start to dislocate early on, why are we waiting until the 9 months to do the cookie test? If it doesn't work, you do nerve surgery where the shoulder is already dislocated. So we have so many variables in these kids. And I like my interaction with you, Maulin, because you talk about them, because we're picking up on things nobody talked about them in the past. You're talking about centuries of talking about very similar procedure on and on and on and on. But we have like 100 variation in this. Anyway, but what I'm trying to say is we're picking up on note, but we have to add more and more because there are so many variables.
Right. So, so what we term in our practice, you know, a positive PADI-REP test is when the primary abduction. Praveen, you want to say something, and then I move ahead.
Yeah. So, as Dr. Hassan told, I think we are on the same ground. We are understanding the same things. One other thing which I want to add is we need to consider co-contractions also in this.
Yeah, absolutely.
Because Maulin told that after the pec major transfer, they have seen improvement in abduction. But one other thing which I observe in many patients is once the adductors are released, also the improvement in abduction happens. So in that one loop which is there in my mind, it may appear like a fairy tale sometimes. So these patients have a co-contraction between the abductor, the biceps, and the adductor. So if you release the adductor, then the abductors have to act less against, fight less against the adductors. And that indirectly decreases the deltoid and biceps co-contraction, straightening the elbow, and then the bicep starts acting better at the shoulder. So yesterday I sent one patient one photograph to Maulin, where just release of the adductor itself improved abduction. So I am actually, Dr. Elhassan, we wanted you to guide us how to treat this group of patients.
Yeah, so that case is also very interesting, and maybe we three should meet sometime on Zoom, and we should share those cases. So let's move ahead. So how we term a positive PADI-REP test when a patient has primary abduction less than or equal to 90 degrees, and after PADI-REP application, the improvement is more than 30 degrees. So it's probably stabilizing, and those children can reach to occiput either easily or with a bit of minimal difficulty. And when the primary abduction is less than or equal to 90 degrees, and with PADI-REP application, the abduction does not improve more than 30 degrees, which we have seen in some of C5-6 cohort, we term it as a negative PADI-REP test. So biomechanics has already been discussed. We know that the deltoid rotator cuff force couple happens. These infraspinatus and teres major from behind and subscapularis from the front compresses the humeral head in the glenoid concavity, and then deltoid and supraspinatus elevates. And this is the concavity compression which is required to produce an effective elevation. But in the presence of weak subscapularis, which we see in C5, 6, 7 cohort, there is an anterior pseudo escape or anterior-superior pseudo escape, as Basim says sometime, which leads to poor elevation. Then we digged into this literature, and the literature said that the long head of biceps has some role in anterior stability. I have talked to many sports people, and they said that we consider long head of biceps pretty rudimentary, but we have seen on arthroscopy, you know, when you see in a child many a times the long head of biceps occupies about 50% of the cartilaginous humeral head. So the width of biceps long head is pretty long, is pretty wide compared to what we see in adults. And that's why we started further digging into it, started doing ultrasound correlation. What I found that at resting point, the distance between acromion and humeral head, cartilaginous humeral head, was like this. When we asked the child to do elevation, the distance reduced, meaning that the humeral head was not compressed well. There was an anterosuperior pseudo escape. And when we placed the paddy wrap, this distance increased, or humeral head was lowered. So we understood that after applying this paddy wrap, the humeral head gets more concentric, although we could not see this on X-rays because of a lot of variables, and we could not do dynamic MRI in our setup because we don't have that facility. But I tried to do ultrasound in many patients, and this was my finding. And so I started doing pect major transpositioning as primarily described by Chuang. But then I modified my technique in the sense that we abducted an internally rotated arm so that the transposition happens. I could suture it to the greater tuberosity as superiorly and as laterally as possible, so that when I brought the arm down, it will act as a very, it's a very stable or a stout rod, which would probably provide anterior stability. And just example, this is pre-surgery abduction. This abduction with a splint, you can see after 50, it turns to 180. At 1 year, you can see elevation, and this is 4-year follow-up. So typically what I have seen that these children improve maximally between 6 months and 1 year. And they keep on improving till 1 year. And in a series of 50 cases, the average improvement in abduction was 74 degrees. So as we got success, I kept on doing this surgery, and because I don't have any other option for this cohort. But in the 50 cases which we have done, we have averaged improvement of 74 degrees. So we can discuss this in further details in future meetings, Dr. Alhassan. But this is what I'm doing right now. And then I have modified, as your advice, a bit more, which I'll tell you later. So any comments on this? And then we can move ahead.
Oh, this is great. This is really, I'm really happy to see this. The thing, Maulin, when you showed the balance of the shoulder, like how the shoulder, the compressive forces, that is very, very hard to apply for obstetric, because the mechanics that you talk about in adult, they're completely deranged in obstetric, completely. And honestly, I spent so far, my 15 years so far of work, I'm trying to understand, and believe it or not, the way I start to understand them early on is from the 3D printing. When you start to do 3D printing and get them out, I start to understand it more and more. And early on, as you are doing, when I try to do things non-traditional, which means not using the conjoint tendon to do transfer, not to release fully the subscap. I remember Alain Gilbert, I remember one time he shut me down in the Naracas meeting, the first time. And then we became very good friends now, because right now he does coracoid excision and he does some of the things we do. Because it's not easy to change dogma. It's not easy to change a pattern that you have been doing for so many years. Realistically, there are so many variables. And I like this one because this one is one of the most challenging problem in obstetric, because everyone talks about Erb's palsy with the flexion internal rotation contracture, but very few they talk about the external rotation contracture. And this one is very, very challenging. I like what you're doing, but you will see over time you may even add or change, because this is what I told you before. I do trapezius for external rotation. I do latissimus for internal rotation. So to balance the shoulder right now, I take the latissimus anteriorly, and this has worked in my hand. In your case, you are playing with the vectors in a good way, and you mentioned it. Like I think Praveen mentioned it. When you take an adductor and you make it as a flexor, now you have two variables. We're thinking only about one, but there are two or maybe three. and we're retrying to rebalance the shoulder. This is why they're doing better over time. This is great. This is very nice.
Right. So, yes, Praveen, your comment, and then we'll move forward. Yeah.
Yes, Dr. Elhassan, I think now we are getting into a very good point. I also felt that LD transfer is a good thing. Though I
Oh,
am
of
not
course.
a shoulder surgeon to start with, so I am more of a hand, brachial plexus, and then getting into biomechanics.
Yeah.
But when we are coming to the muscle release transfer operation, most of these patients with adduction contracture, we anyway release the adductors. So when you are going to release the latissimus dorsi, that is maybe the best transfer to put to the subscapularis area. So I have done that and I felt like that works quite well. I am little bit concerned about doing the pectoralis major translocation because many of these patients are girls and they come when they are around 10, 11 years. So all are very much concerned about the scar over the anterior aspect of the chest. But latissimus dorsi is quite good in that aspect. So
This is the best thing about this kind of meeting, like
yeah.
when you discuss things rationally. But by the way, this is a new, all of this is new because Lepiscopo, release pec, release lat, do transfer, release subscap, they end up with external rotation contracture and they say this is the surgery that make the mothers cry. But these are the kids, they end up coming, they cannot put their hand on their belly. And this is why this is great.
Yeah. So let me move ahead. The another sign after pedirep test is external rotation contracture, which we see in these children, or in other words, inability to reach midline. What is the etiology of external rotation contracture? The one is the iatrogenic, and the second is non-iatrogenic, which we observe. And iatrogenic because there is excessive internal rotator release and tendon transfer, or even if you do a limited internal rotator release and tendon transfer in a existing weakness of internal rotators. So if you fail to examine the child well, and they have not able to reach to the, so it's, if it's a C7 cohort to start with, and so when they have already, they are not able to reach behind the spine, or they are not able to reach to the, the pocket. So they have pre-existing internal rotator weakness. And if we do conventional operation, they also end up into external rotation contracture. So this phenomenon we know, but we have seen that the patients who have predominant C7 root palsy, they would also have internal rotator weakness because lower subscapular nerve is supplied by C7 and upper subscapular by C5-6. So these patients without any iatrogenic injury can have this picture. So let me show you one child. This is 5-year-old. This is the iatrogenic external rotation contracture example. So I did this surgery in 2012, anterior open release and conjoint tendon transfer. She improved in abduction and external rotation. As Basim said, she was not able to reach midline. And then in an attempt to do midline function, her scapula would move out significantly. And then I realized that this is not a good surgery, because you release everything from the front, you transfer internal rotators to the external rotator, so there is nothing remain behind to move the child internally. And moreover, you give a spike line 90-degree external rotation, which pronounces this external rotation. So I stopped doing that, and that's how minimally invasive subscap release came in picture. And from 2013, we started doing limited release. Now let me show you this subset. So predominant C7 pulse, this is not yet described probably in literature. Now we see some children infants who have anterolateral deep crease. In typical C5-6, we see adductor, internal deep crease, or on the medial side, and deep axillary crease. But we see some kids with anterolateral deep crease. And when you try to do a passive internal rotation, we were surprised in a 3-month-old baby, we could not internally rotate. You see, there is a deep crease on the lateral side. On the normal side, we can easily passively internally rotate, but on right side, we cannot. And they have very good degrees of external rotation and elevation. This is a predominant 7-8 palsy with a Horner syndrome, and you can see a deep crease on the anterolateral arm. When you leave it, it's like a spring, it goes back. Child can do abduction and external rotation like this, but we could not do passive internal rotation. So I was so surprised that external rotation contracture can develop so early in the life. And we have started applying what's known as a Vulpius sling for some of these children to keep the arm in internally rotation and adduction. We have seen some of these children when they grow up, when the arm is abducted and we try to do internal rotation. Here the left side is normal, but there is full internal rotation. But on the right side, child legs last 45 degrees of internal rotation. In other words, these children have what Basim said rightly is an external rotation contracture. So we have never been thinking about external rotation contracture, but for this extended ups palsy cohort, this sign should be taken in consideration. Another example, this girl on the right, she has full degrees of internal rotation. On the left, she is lacking 45 degrees of internal rotation. And when we ask them to touch their belly, they are touching the belly with wrist flexion or belly press test. They have to flex the wrist, and some of them are so severely affected, they are stuck in external, they cannot reach. So we cannot perform a typical subscap release and tendon transfer in this patient, where we will worsen the situation. And we know that Scott Cousin and group had described this sign of hand to belly internal rotation as one of the important Mallet score. And we know that we score them like this: 2, 3, and 4. 2 is they are stuck external, they cannot touch the belly. The 3 is they are touching with wrist flexion, and 4 they can touch with the palm. So my questions to panelists is how an external rotation contracture, along with terminal limitation of external rotation and abduction, would alter decision making in your shoulder rebalancing surgery. So Dr. Alhassan, how would you manage? You have said it partly. You said that you would transfer leg dorsal to subscapularis, but now we have to also reach behind the occiput, we have to improve, and we have to do this. How all this gamut can be addressed in one sitting, or you stage them?
Well, I'm really very happy you're talking about this topic, because I try to talk about it for a long time, and it's not easy for surgeons who do only brachial plexus to understand it. And I'm glad the group here, really, they are very, aware of it, and you're working on it. Because this problem, in my opinion, is much harder than internal rotation contracture. Internal rotation contracture, there are a lot of ways to deal with it. External rotation contracture is not. It's very, very, very hard, because in this case, you have to do a full release of the posterior inferior capsule. Otherwise, it's useless. Whatever you want to do is useless, because whatever you want to do, the muscle is not going to bring it back. And the capsule is super, super tight in the back. And sometimes we talk always about the subscap contracture. Nobody talk about infraspinatus contracture. Nobody talk about teres minor contracture. And this one, they happen. But because the shoulder is so external rotated, it is relatively, there's no dislocation. It's relatively easier to release the capsule and internal rotate the shoulder, and you can stretch these muscles, and then you do something additional. So for me, again, if you want to go back to your graph about balancing the shoulder, the only way to balance the shoulder is, first of all, to release the contracture, to get nicely passive internal rotation on the table. You have to see this on the table, and then do your tendon transfer, then completely put them in this position to let them balance. Now, does this can cause internal rotation contracture? Very unlikely, because they still have the external rotators. So this is our only hope to balance the shoulder front and back, in my opinion.
So for limitation of abduction and limitation of terminal external rotation, you would do some procedure in stage at the later in a second stage?
Yes. So Mola, you have to, this is something now you are getting into it. This is why our discussion, I always like our discussions. When you balance, so this is the biggest, not mistake, I will say, misunderstanding. You showed one graph about it. And this is what I have worked on it a long time. How does the shoulder function? Regardless of the scapula, which is a different story, I can talk to you about scapula from now till tomorrow. But let's talk about the shoulder itself. You need a rotator cuff to hold the humeral head for the deltoid to function. So if the force couple balance well, the deltoid work. So right now, abduction, as long as you have a balanced shoulder, if you have deltoid, it's gonna work. There's no problem. If I have a problem with external rotation, I can deal with it later. But let me deal with internal rotation. This is number one. Number two, all of you on the panel today, tell me how often you use your arm external rotations beyond neutral per day. How often during the day, when you external rotate your shoulder, you use external rotation beyond 10 degrees? I'm talking 20, 30, 40. Rarely ever. We don't use them. This is our work. And for whatever reason, for 20, 30 years, this is what they want the patient to be in, and they end up with this external rotation that you don't need. Why do you want to need it? You put your hand this way, and after they start to type, they cannot hug, they cannot type their pants, they cannot do the zipper. I have mothers coming to me, I cannot hug my daughter. I cannot tuck my pants. I have 3 years old telling me, I cannot reach my belly. And we keep on focusing, getting this external rotation, which we don't need.
Right. Yes, Praveen, you want to say anything about external rotation contracture? So I like this plan. You know, so far we were still in this dogma of external rotation improvement. We used to do with external rotation surgery, and then in second stage I would do leg dorsal. So gradually I shifted from a double to a single transfer, single tendon transfer. Will transfer teres major to infraspinatus and leg dorsal to, I'll preserve leg dorsal to subscap. And I started doing arthroscopic posterior capsular release. But I think we should do the internal rotator, arthroscopic release and leg dorsal to subscap transit stage 1. Probably that will take care of deltoid, the abduction if deltoid is innervated. And then for this, we can do in a second stage, but some of them, they have the posture of the arm is problematic. See, some of them have triceps weakness leading to elbow flexion deformity. And when the arm is little bit internally rotated, the point of elbow is projecting. So they have more cosmetic concern in some of the cases. So we have to balance.
So Maulin, I assure you that if you try to get the internal rotation, you're not going to end up with trouble, because these patients, they have a very high tendency to get to rebound back into external rotation. So I am not worried about it. And you'll be surprised, some of them, just with this procedure, they'll be able to get this. You'll be surprised. Just try it. We'll see. Since you have a large volume, we'll see what's going to happen with you.
After communicating, I've done 3 of them, and they are all in follow-up. One child, we removed the spica 10 days back, but she had fever. So I said my therapist that I want her to reach to belly before I start this meeting. But unfortunately, the child had fever, so she could not join the rehab.
Sure.
Anyway.
Yeah, okay.
An external rotation contract, we have heard that that you do arthroscopic release. Have you ever required to do release of infraspinatus or teres major, or just the capsule?
This is a mistake though, because why do we release the subscap? This is a problem. This is a problem because for years we are used for the posterior dislocation and the glenoid deficiency. And this is something we haven't spoken about today. This is a different story, because if you don't correct the bone, you're going to dislocate again. But the biggest problem with the subscap, they're so tight, you cannot reduce the shoulder. Yeah. The shoulder is reduced. The shoulder is nicely sitting in place.
So I don't need to cut the muscles.
Exactly. Worst case scenario, if you're really, really very, very bad, you can Botox at the time of the surgery, release posterior capsule. They're gonna have 3-week external rotation, but after 3 months, they gain it back, and that's it.
And then you can do your spica in a proper position. So you answered this question, whether in same sitting or separately, your policy is to deal with internal rotation to start with. So yeah, we have started doing this. Yes, Praveen, I'll come to you in a moment. So we're starting with this, Praveen, arthroscopic posterior capsular release with my arthroscopy friend. And then, as Dr. Alhassan said, this is where it started and where it ended. So we could completely brought the arm in internal rotation with just capsule release, and we have not touched the muscles. So now what I did with this is I did teres major to infraspinatus transfer, because she was reaching there and not there. and I told parents that I might do internal rotator transfer if child doesn't have strength enough. So in the second stage, but now I might reverse my order. Yes, Praveen, your take on this.
No, I just wanted a little bit clarification from Dr. Elhassan and you both. You told, like we discussed many of the things in sequence. Can you summarize what you will do for a patient who has an external rotation contracture? So Dr. Elhassan told about release of the posterior capsule. Then he was telling about LD transfer. Is there any sequence which he follows, or every patient would undergo this combination?
No, every patient will go into this combination except. So I know both of you have seen this. If you look at the MRI on these kids, the subscap look normal, but they cannot interrotate to the shoulder. Now, for me, I think it could be this connection. It could be denervation. At the time it re-innervates, the connection between the brain and the subscap is gone. Then you have a muscle that's working, but it's not contracting. So this is where the tricks come. If the subscap look really perfectly normal, you can debate whether or not, because now it's stretched because the shoulder is out. Once you release, it's not only posterior inferior capsule, by the way. You need to release the inferior capsule as well, because this is the same part. And you have this now nice, beautiful function. If the subscap look perfectly okay, you can take your chances, even though I doubt. You take and tighten the muscle, the tendon, because it's stretched. And there is a chance, I'm not very sure if you can get it back. However, for me, I don't take chances. Every patient who have external rotation contracture, they get the release and the latissimus transfer at the same time. But you can tighten the subscap at the same time.
Where do we transfer the latissimus dorsi? Do you transfer?
This is a great question, because these patients, they have supra-infra. So in adult, I have a lot of lectures about this. If you have supra-infra, you transfer the latissimus to the anterior superior part of the lateral tuberosity, because it gives you a better lever arm. So anterior superior part. And you know the gross plate of the case. Just make sure like you'll be able to put it in a way that don't affect the gross plate. So you have to bring it lateral, anterior, lateral, proximal to the lesser tuberosity.
So now I have heard that you do it, you deliver it arthroscopically. Now, yes. I could do this, we are well versed with the axillary approach, where we can easily retrieve lat dorsi. And we can also see, if we go in front, then axillary pedicle is there. And then in front, that comes the subscapularis, which inserts into lesser tuberosity in the front. So I can do it pretty easily from here to here. So is that okay? Because I don't need to do arthro. Can we do it?
Bola, you're like, I'm not used to this approach. You're much more comfortable with it. So arthroscopically, I harvest this way. I take it arthroscopically and pass it out with one very small incision. For you, you're doing the same, but you're doing it open from two approaches. For me, I do it from the front.
Yeah. So I just use one approach, and we can do the myolysis till the lower end of scapula through this approach.
I got you exactly, because you're inferior with the subscap is you take it and you pass it directly. Yes, absolutely, you can do it this way, as long as you put it exactly where you want to put it.
Yeah.
That's the point.
So I'll send you some videos and photographs, and you can guide us whether it is right or not. So Praveen, did you got your answer here?
Yes.
So what he's saying that with this internal rotator transfer, the anterior stability will be taken care of. And so the elevation, which we think that anterior instability, that can get, if deltoid is innervated, child would start doing abduction. That is one. And if child has real concern of reaching behind the occiput, we can transfer teres major to infraspinatus if it is required. But he said that most of the children, they start. Now the question is, you are also saying release of anterior capsule. So what is the position of your spica? How that
not anterior capsule. No, anterior capsule not for the posterior part. Posterior inferior.
Inferior. Okay.
No, because it's the same capsule, by the way. Because if you release posterior only, it will not be enough. You have to get inferior to get
come down.
See, when you do this is inferior now. So you get posterior. Anterior, I don't touch it. It's already stretched.
Yeah.
How about just inserting the latissimus dorsi to subscapularis insertion tendon, so that you
it's not a bad idea. It's not a bad idea. It does not give you as much leverage, but like the minute you get this nice motion that Maulin showed, it will be so nice to get it even more lateral to get more leverage of internal rotation.
So this is the position of spica, Praveen, we apply now. What I term it as in Tathastu, or this Ashirwad, for blessing pose of these gurus. We had bit of a forward flexion. The children who have C7, they have weak pronator. So I apply it in the forearm in mid prone, and usually they look like this. There's 90-degree abduction and bit of forward flexion, 20-30 degrees, and a bit of internal rotation and not full external rotation. So that's how I started. Again, this is what Basim told me to do so. Fine, let's discuss quickly the last sign which we see in this subset. That is, I term it as a forward trumpeting, forward flexion at shoulder for hand to mouth motion. Now we know that typical trumpeting is lateral, but we see some of these children, they have to forward flex their arm in order to reach to the mouth. And I have not understood exactly why it happens. So let me show you this 5-year-old boy who underwent Botox injection in subscap and pec major. He has good active external rotation, as you can see, with arm adduction and abduction. And abduction is limited to 90. Again, the same thing. They cannot go beyond. When we put pedidap, it goes beyond, improves by 40 degrees. So I term it as a positive pedidap test. But when it comes to hand to mouth, child has to bring this arm forward like this. And some families are concerned. Now, again, they had also limited internal rotation, as you can see here. See, he has to flex the wrist. So I feel that these all signs go together for this subset. Now see his lateral profile, how he moves to does the hand to mouth motion. And so family is concerned that this looks very bad and we want to get it corrected. So my question to Basim, what do you think? What can be the reason of why child is doing forward trumpet? Some of them, we have done tendon earlier on, they had lateral trumpeting. Now they end up doing this. So what is happening here?
For me, this kit is very similar to the same cases, by the way, because it does look like an external rotation contracture. He has internal rotation weakness. He has some triceps weakness. Biceps weakness. It looks very similar to me, but little bit changes in the muscle powers. This is very interesting because every case you showed right now, all of them, they have essentially weak subscap.
Yeah.
Like our typical herbs, 80%, they're internal rotation contracture. This one is external rotation.
Yeah.
And they're showing differently depending if the biceps is weak or triceps is weak. Because if the biceps is weaker, they're gonna go forward. And if the triceps is weak, they're gonna be the same way that you showed it before. They're gonna try to do something like this. So in my opinion, I think it's a combination of these. I think in this case, the biceps is weaker than the one showed before. External rotation contracture, or at least posterior capsule contracture, weak subscap for sure.
Yeah. So Praveen, your observation or your comment on this? Have you observed this phenomenon?
Yeah, very much, and it is very interesting. So I think one of the things to what you already told, one other thing to add is the abduction contracture in these patients.
Yeah.
The deltoid also is shorter. So what I think, there is the cycle in my mind, which one is happening is the typical lateral trumpeting is more common in patients who have abduction contracture, delayed recovery of biceps, because when the biceps is weak, they are able to use this trumpeting add on to their flexion, and then they get into a habit of doing this. The forward winging of scapula is more common in patients who have recovered everything and they are remaining with some internal rotator weakness.
So Maulin, this patient did he have a prior surgery?
So I did Botox when he was 1 year old, 11 months, and later I did this triple tendon transfer. I talked to you about this child in the sense that I did infraspinatus to teres major to infraspinatus, pec major transpositioning, and leg dorsal to subscapular in one sitting. But you told me that if you do everything together, these muscles can co-contract and this may not work well. So what has happened is this child has gained nice external rotation. His elevation has improved. but he's still not able to reach midline. So what I have not done is, we have not done capsule release arthroscopically. We were very young. My colleague, arthroscopic colleague, was saying this, I have never done in a 2-year-old. But now I have pushed them, and now they have started doing it for me. And I have not done scope anytime. So
yeah,
so this is not a post-op phenomenon. Let me tell you, this is not post-operative finding. This was there before surgery also.
No, I'm talking about abduction contracture. So the abduction contracture, I've seen it if you have an internal rotation contracture with abduction, I've seen so many. But when they have external rotation contracture, I haven't seen it as much except post-operatively. This is what I'm trying to say. So when you mentioned about abduction contracture, this is why it clicked in my ear. I've seen it so many because this is almost like an autofusion. When the arm is stuck, you can see the scapula winging out and everything else. I've seen it post-operatively in external rotation contracture. I've seen it so many times. It is very difficult in internal rotation contracture. This is why I asked if he had prior surgery. It makes more sense.
Yes, I have not thought in greater detail, but I also do not recollect patients who had external rotation contracture and abduction contracture, but some of them are post-operatively, they get stuck. Anyway, so can we improve it? That's a question to you.
I think so. Yes, I think so. I think so still, but we have, because he's still very young, right? How old is he now?
He is, I think, 3.5 years old, 4 years old.
That's perfect. It's the great age. I really, first of all, I know he's okay. I really want to make sure that his shoulder is okay, like CT scan, to make sure the bone. Yes, please. They're very, very important to make sure the anatomy is okay. If the anatomy, the bony anatomy is okay, I will follow the same approach, at least to balance his shoulder. Right now, he's stuck. He's completely stuck. And these kids, by the way, if you leave them right now and they grow, every year they start to lose more motion because 80% of his motion is scapulothoracic.
Yeah,
is moving. All the scapula is one unit and trying to move it, he's stuck. So for me, if I want to balance it, this is the best age to balance him. And this is someone I will do the same what we spoke about before. And I will focus about the shoulder first, try to release the posterior capsule and try to get him internal rotation, see how he's going to do, and go for another step after that.
Now, there are some children where they have been operated at other center, where they have done conjoint tendon transfer and anterior release, and they are stuck outward. So now lat dorsal is already transferred to infraspinatus or posterior capsule.
Yeah.
So have you done that?
Honestly, for this kid, I will take the latissimus out. I know you don't like it. I will release a capsule, and then as a backup, I will do lower trapezius transfer later if you need external rotation.
Okay. So you still would take lat dorsal from the posterior capsule and shift it to subscap.
Because there's no way you can correct him otherwise. Because if you release the capsule only, this kid, if you look at the latissimus, is going to be super tight right now. Yeah. So if you don't release it right now, there's no way he's going to regain external rotation. And I bet you his infraspinatus is working.
Yeah. So Praveen, you know, this, as you said, when you ask him to do abduction, you can feel the lat dorsal tight like a cord. Yeah. You know, in some of your patients you've mentioned. The thing is, other problem which our children or parents complain that they gain abduction, but their triceps is weak. So when they try to put something overhead,
they felt
like this. When they want to put up, their elbow is like this. So how to deal with triceps weakness? That's a question. Can we do something to?
Yes. So this is what this is why the planning is very, very, very important for these kids. Have you tried the lower trapezius to triceps?
I have tried in one case, but I'm not successful. With 1 year follow-up, there is only few degrees of improvement. I can share the slides of those patients to you. I followed your technique. Yeah.
So Maulin, but the problem with these kids is the flexion contracture as well. So the elbow contracture, everyone talk about capsule release. It does not work. In patient with the flexion contracture of the elbow and weak elbow extension, you have to correct this flexion contracture first. And in these kids, if you do only release of the capsule, in my experience, they don't work at all, or they work very little. You have to release the brachialis and attach it to the biceps to get full extension of the elbow. And then you do the transfer for it to be able to work. Otherwise, there's no way it's going to work.
Okay, so let me share this case with you. And that this girl, I remember she didn't have any elbow FFD. but still, I don't know what happened. I mean, I followed all your steps described in paper step by step because I was really keen to get this, because that's a major problem. Anyways, let's move to the end of this session. There was great session. So what I have summarized from my observations, and you would all agree, that C5-6 cohort behaves differently than the C5-6-7 cohort. And this is a time to understand these differences. And both of them, they need different line of treatment. We cannot give one remedy to all. The first thing is, in C5-6, external rotation is mainly more affected than abduction, or sometimes they are equally affected in proportion. But in extended Erb's palsy, we have seen abduction is more affected than external rotation, and internal rotation is what's main issue. So when we put a paddy wrap, it is negative usually in C5-6 cohort, but it turns positive, meaning that they will improve in their abduction by this mechanism, multiple variables we discussed. The triceps is stretching out, or biceps is stabilizing, or so paddy wrap test becomes positive in extended Erb's cohort. The typical Erb's palsy have internal rotation contracture. Extended Erb's palsy have external rotation contracture, which you can check as we shown here. And hand to belly or spine is usually possible in C5-6 cohort, but it is not possible with the palm. Children might need to flex their wrist to reach to the belly. Triceps strength is normal in C5-6 because triceps is innervated by C7-8T1, but it is suboptimal in extended Erb's palsy cohort. And finally, trumpeting. The lateral typical trumpeting we see in C5-6, but this 5-6-7 cohort has shown the forward flexion to reach to mouth. That might be because of biceps weakness, triceps weakness, or external rotation contracture. So this is in a nutshell I was interested in bringing to the notice of all my colleagues. So Praveen, you had to say something. You raised your hand, and then final comments by Basim, and then we'll finish it. We are 2 minutes ahead, and Basim has to go somewhere else. Yes, Praveen.
No, I agree with all this, and you have presented very nicely. So also, if the patient has got a global involvement to start with, then all these signs can get intermixed.
Right.
So that is the place where I think.
Yeah. So I agree. No, we have studied, Praveen, 350 patients, wherein we divided them into infants and older children. So infants, so we have around 240 children in C5-6 and 60 children in C5-6-7 cohort. So this means that about 25% of patients have this affection, and 75% had typical C5-6. And we have taken off the panplexopathy patients because they may have intermingling of these signs. But my motive was to purely differentiate between C5-6 and 5-6-7 because they combine 80 or 85% of the full Erb's palsy cohort. I mean, the brachial plexus palsy cohort.
Correct.
So I agree with you. We should not consider this sign when we are talking about panplexopathy.
And in birth palsy, I think more difficulty is when to apply that grading, whether it is C5, 7 or extended, because they keep recovering, whether it is a birth, whether it is 1 year.
Yeah. So this is a separate talk. We have done a lot of thought process that the Narakas and the Al-Qatan people have devised the Narakas 1 or 2 at 2 months. But this signs change by the time they reach 6 months because all the exontemesis injury would improve. So we have seen this findings after 6 months and between 6 months and 1 year, and older children who can perform some activity when we ask them to do. So we have 2 cohorts. I'll share that data and we can work on it together. Yes, Dr. Basim, your final comments, and then we'll wind up this
honestly, I truly enjoyed this section very much. This is one topic you don't hear about it in any brachial plexus meeting. And I am a big fan of this because this is what has been missed for a long time. And a lot of people, they don't understand this one, which is, I'm very glad you're tackling this problem. I think for we have to keep on working on this one. We'll keep on thinking to help our children, you know, like over time, we'll try to have to figure out more and more solution. One more comment, only one comment I want to mention, and this is for future meeting. When you showed your case that you've done the conjoint tendon release and they end up with external rotation contracture, the problem that we have is the outcome of the papers that we have over the years. Most of them, they have this technique where the kid is placed in the Statue of Liberty and they end up with external rotation contracture. And they have a great Malay score before Scott Cozen added the internal rotation. But this Malay score, because it all talk about here, and external rotation, they don't talk about internal rotation. And I think some of these papers are so much biased, we cannot even compare our current literature to it. And this is the biggest, for me, this is the biggest change that we need really to implement in the 567. I like this kind of table about comparing 5.6 to 5.67 because I think this is how we can differentiate them. But I think in your table, you should add surgical versus non-surgical because some of them, it's exactly the same picture, but because they had surgery before, they end up with the same image.
I agree. So I have shared this presentation to both of you, and you can send your suggestion how we can. So I understood what you said, that those non-operant or non-iatrogenic C567 and iatrogenic C567.
Yeah, yep, exactly.
Thank you very much for your time, Basim. We enjoyed. Maybe we might have a research meeting where me and Praveen can present our streamlined proforma, and we can prospectively enroll our patients to come to some meaningful conclusions, you know.
Yeah, no problem. And let me know. I'm happy to help or coordinate. I'm happy to help as well.
Thank you very much. Take care.
Bye-bye.
Bye-bye. See you. Thanks. Delegates, any question? Gaurav? Probably this was a bit of, you know.
Yeah, so it was like, yeah, so I was able to be with you for the 40 minutes. I mean, the initial 40 minutes, but the last time, and it was a bit over my head. And I think it would have been a roller coaster for all of our delegates also. So I haven't heard any question on my WhatsApp or on the chat box. Yeah, so one question from Dr. Tejas. What could be done for FFD? I mean, FFD where he has not mentioned.
Elbow FFD, I think. Yes, Praveen, you can answer that question.
Yeah. So we have been regularly doing only serial casting, but I am aware of some people who have reported surgical release with good results. Surgical release should be release of the capsule, release of the brachialis, transfer it to the biceps. We should avoid lengthening of the biceps because that would decrease the flexion power. So we have done open release for the elbow for only 3 patients. But in our hands, serial casting has worked quite well, and we would not need more than 50-60 patients. And it gives good result, but it has to be maintained after the correction is achieved. Child has to be on elbow extension splint till they attain maturity.
Right. So I reviewed one paper recently, I think that was from Current Orthopedic Practice. And when the elbow FFD in brachial plexus moves beyond 30 degrees, they have also done the excision of the tip of olecranon. So what they said, when there is long-standing elbow flexion deformity, there is hypertrophy of a tip of olecranon. And so when you release anteriorly, you cannot correct it completely because that's a posterior block. So that was a nice, I mean, I accepted that paper with some changes. I'll send that copy to you. And so that is, but my approach has also been like, I was always in fear that not to lose hand to mouth, you know, by dealing one cosmetic problem, you might give another functional problem. So we have, our approach has been conservative, but we should not touch biceps. That's the rule. Yeah. Any further?
One more question I have from Dr. Shalin. What would be extended Erb's palsy? As Narakas described it as wrist extension limitation, here it would be a triceps weakness, a different classification. I mean, he wants to understand what should be the better sign, either a wrist extension limitation or a triceps weakness for extended Erb's.
Yes, Praveen, you would like to answer this question?
Yeah. This is what I meant when that there is no clear boundary between the C5, C6, C7. So suppose you ask me what is pure C5C6 when the triceps is normal, then it is C5C6.
Right.
Suppose the patient has weakness of triceps, that means C7 is weak. The Naraka's classification stresses more on wrist extension, but wrist
Yeah.
extension also is partly by C8. So if
Right.
wrist extension is weak, that means you are going towards T1 hand. It is not only C8 and T1. So triceps is normal, then only we will call it pure C5C6.
So this is Shalin, which I am also teaching you guys. Partly I came to this from Peter Waters that we should see triceps, but unfortunately there's a Naraka's classification. They have not mentioned about triceps, and even in Al-Qatan's classification of type 2A and B, again he mentions early recruitment of wrist extension and late recruitment. There also they don't mention about tricep strength, but all the functional problem happens because of weak triceps. So when we follow them, we should see whether they have tricep weakness or not. You see that limitation of abduction, limitation, they all is happening with the triceps. So triceps, so Praveen, we have to come with some new classification.
Yeah.
Because they, I have seen all the wrist extension. If triceps is functional, the wrist extension improves by 1 year. So triceps is first to recover. If triceps is not there, there would be there are many patients who have persistent wrist flexor deformity. The other problem is we do not have good tendon transfers with triceps strength. We know we have good like Green's transfer we can do for wrist extension. So I think that we should have a good nerve surgery for triceps earlier on if triceps is weak, because in later on we don't have very good tendon transfer surgeries. Although Basim explains, I've done in a couple of them, lower trapezius to triceps. My success was very poor. So I'll share that case also. It has not worked well.
In that, what Dr. Elhassan described and also initially described by Bartelli, the lower trapezius to triceps, they tell good result. But I think one thing which, as you are telling, ours also half of the patient, no improvement happened. But when I'm trying to study all these patients, it is looking like the patients who failed the surgery were the one who have very severe deltoid biceps co-contraction. So that group, whatever you put to the triceps, this co-contraction eventually overpowers the triceps and they remain flexing the elbow whenever they are abducting the shoulder.
Yeah.
It will work well in a patient who does not have too much of deltoid biceps co-contraction. So if you get some patient who is having bit of kind of paralytic type of brachial plexus palsy, you understand, that co-contraction cycle is not much. For them, it work very nicely.
Okay.
So, the presentations, I was myself seeing my presentations whenever we have shown a good result of trapezius to triceps. Those patients, if you see preoperatively, they don't have too much of deltoid and biceps co-contraction. So whoever is having deltoid and biceps co-contraction, they are likely to just get stuck with the same thing in spite of giving triceps power.
So you might use a Botox when you remove the spica or plaster, you might inject in biceps.
I'm scared of that. I don't know. If some elbow flexion reduces, then it is going to be a big problem. So that is the thing. Correct.
Fine. So more you treat, we know that there is more to know and more to learn and understand. So I hope this webinar will start igniting that thought process in all the delegates. And I'm sure we should come up with a new and a better comprehensive classification and just not the Narakas. We have to move ahead from here. Thanks, Praveen, for your valuable time. Your comments were of great help. And I'm so glad that we are on the same page so we can combine our efforts to come to some meaningful research. Thank you very much.
I'm also very happy to join, and I was very surprised to see Dr. Elhassan is having same type of thought what both of us share. So I think he's trying to like putting icing on the cake, no? So whatever we are knowing, he's just putting some extra point to that. So I'm very happy today. So why not we make one? We'll talk about that. We will make one nice pro forma. We involve him. He also has similar type of patients. And we chart it out. And I have prospective 41 cases now, because I was somehow not happy that maybe our retrospective thing, we may be missing something. We chart it out and let us come out with something big.
I was about to present this abstract in our Palsy annual meeting, and I'll share that data with you also, the statistics. So we have 340 patients, and we have studied this. Fine. Right on. Thank you very much, delegates, for a valuable time. Thanks, Gaurav, for